Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of January 23rd, 2023. After an update on COVID and the variants, I will talk about a couple of innovations on the horizon, as well as some CDC and FDA upcoming changes. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Here in Alameda County, we can see that total cases over the previous 14 days continues to decline, and the percentage of tests that are positive is also coming down, now at 5% positivity. Thankfully, hospitalizations are also coming down. We now have 117 COVID patients in the hospital, 12 of those in the ICU. And taking a look at our wastewater data, we can see that that is continuing to come down as well, with the last date reported here of January 12th. So as it relates to COVID deaths, unfortunately, the daily average is now 574 deaths per day, which would equate to over 4,000 deaths per week. So this is still quite high. In fact, since the Omicron surge, you can see there in January of last year, even though it came down substantially, it has never come down quite far enough. We've been hovering somewhere between 2,000 and 5,000 deaths per week for the past 11 months. And we know that deaths are a late indicator, as they tend to happen weeks or more after the initial diagnosis. So in the past, we'd say that we would expect deaths to come down after cases are coming down. But increasingly, that is not necessarily the case anymore, meaning that we've seen kind of a decoupling of the cases compared to the deaths. So cases can be flat or coming down, and unfortunately, deaths are kind of staying where they are, which again is too high. So that tells me that we are missing opportunities to keep people out of the hospital and to keep them from dying. So this is something we really need to be working on. When we look at the CDC's forecast of new weekly COVID deaths, they have modified these forecasts to now be trending down. And the prediction is that we'll be somewhere between 2,500 to 4,000 deaths per week into mid-February. Again, still too high, but certainly this is better than what we were bracing ourselves for. When we take a look at variant proportions, we can see that the nowcast variant proportion forecast from the CDC has XBB.1.5 at over 49% of specimens. And when we look at the proportions by region, we can see that still the Northeast region has over 80% of XBB.1.5, while other parts of the country, it's pretty variable. Some are even as low as 10%. I did mention the CH.1.1 variant several weeks ago because there were a handful of CH.1.1 sequence cases here in the state of California. Right now, these are not being separated out on the CDC tracker. They're being lumped in with their parent lineage, which is BA.2.75. Once a variant reaches over 1%, that's when it gets its own color on the CDC tracker. So we'll just be keeping an eye on that because it does have some concerning mutations that we are concerned cause more severe disease. But the good news about CH.1.1 is that it doesn't seem to have any growth advantage. It's not increasing at a concerning rate at this time, but we'll continue to keep an eye on that. So to sum up where I think we are with COVID at the moment, we're doing better than we thought we'd be doing at this time of year. So that is saying something. We're definitely doing much better than we were doing last year at this time. Of course, last year at this time, we were doing pretty horribly, and we weren't expecting to have a repeat of last year. But at the same time, I think this is the first time I can recall in the pandemic that we're doing better than we predicted. So that doesn't mean things can take a turn, but I don't take this lightly. It is nice to be doing better than expected for once. I definitely find it reassuring that case counts, percent positivity, and hospitalizations are all decreasing. We know that case counts are not reliable anymore because of the amount of home testing, but seeing hospitalizations and wastewater trending down here locally and on average nationwide is reassuring. there are still hotspots when you look across the country. So we should all be looking at our local area to understand our local context. But despite the positive trends, deaths are still too high. We're at over 4,000 deaths per week currently, which means that COVID-19 still is a leading cause of death in the United States. And that's despite all of our tools and all of our advances that we've made over the past few years. So we're still just losing way too many people to this infection. And we know that this is in large part because we don't have enough of our vulnerable population. So our elders and those at high risk of doing poorly with COVID, we don't have enough of them getting their boosters or getting treated if they turn positive. And we know that not getting treated when someone turns positive, it can partly be an access issue, but it can also be due to not getting tested in time. So if you're not tested in time, you're not diagnosed in time, and then you can't start outpatient treatment in time to make a difference, to stop that progression into the inflammatory phase of COVID, where we know that people take a turn and have to be hospitalized. So to avoid hospitalizations and death, we're really going to need to improve upon our uptake of boosters for those who, especially for those who are over 65 or those who have underlying conditions, and outpatient treatment, particularly for the same group, those who are at high risk of progressing to severe disease. The fact that our monoclonal therapies are now ineffective against our circulating variants is of major concern. We are going to need an alternative strategy for those who were really relying on monoclonal antibodies. And remember, this includes people who are immunocompromised and don't mount a good response to the vaccine. And this also includes that small percentage of people who for some reason are unable to get the vaccine. So having a monoclonal antibody treatment for these groups of folks that offered 6 months of pre-exposure protection, so actually keeping them from catching COVID, was a huge advantage. And now we have completely lost that advantage. We've also lost monoclonal antibody treatment, which was a great alternative for those who, for whatever reason, couldn't take one of the other treatments that we have available. Again, this is a relatively small subset of the population, but there are medication interactions that we know about with some of our treatments, and also certain severe conditions might preclude you from getting some of our treatments. So the monoclonal antibodies were a great alternative for those folks, but now that is really off the table. So we have sort of a hole in our armamentarium now against COVID, and there's really no timeline that I've been able to ascertain about getting new monoclonal antibody treatments developed or approved. We still remain vulnerable to new variants because we continue to have transmission all over the world. And at any point, a new variant can come up and can take hold and can outcompete the other ones around it. And so we're still in a bit of an unpredictable situation as it relates to variants. I'm reassured to see that surveillance is continuing in several parts of the world. So we really do hope to see that maintained. I think this will be a big key to us staying ahead of SARS-CoV-2. And the last point here, which I think is becoming one of the greater concerns, as we see that millions of people are being affected by long COVID. I reviewed this in some detail in last week's briefing, so check that out. The fact is that we just don't know enough about who's going to get long COVID, how long it's going to last, why it's happening, who it's going to happen to, how we're going to address it. So with all of these unknowns, it's really worth continuing to be vigilant and avoiding catching COVID or re-catching COVID, since that's really the only way to avoid getting long COVID, is to avoid getting COVID in the first place, at least for now. Briefly on flu before I talk about some advances in COVID. For the week that ended January 14th, there have been a total for the flu season of 270,000 hospitalizations and 17,000 deaths from the flu. 85 of those are among pediatric patients. Flu and RSV activity are continuing to decline in most areas of the country, so we're feeling a bit of a reprieve there as well. So now I want to briefly discuss a couple of potential hopeful advances. The first one aims to address one of the big problems, which I just talked about, which is that we no longer have protection for those who are severely immunocompromised. And this group of folks who are severely immunocompromised have also really been underrepresented in a lot of the studies that have gone on. And so this was a small study recently published in the Journal of Infectious Diseases that looked specifically at this group of severely immunocompromised individuals who were hospitalized with COVID-19, and they were given what was called a SARS-CoV-2 hyperimmune globulin. And again, this is to severely immunocompromised hospitalized COVID-19 patients. Remember, our big concern with those who are immunocompromised is not only that they might not have all the defenses to fight the SARS-CoV-2 infection, but also that they may not have mounted a good response when they got the vaccine. They still should get the vaccine because we expect them to mount some response, but it is very variable. So they may not benefit from the protection of vaccines like others would, and then that leaves them more vulnerable to the infection, and they're already more vulnerable to bad outcomes from the infection by virtue of being immunocompromised. So this is really a group of folks we absolutely need to be very concerned about and be focusing on what to do. So what they did was take what's called convalescent plasma from donors of people who had a history of having recovered from COVID-19 at least 2 weeks before they donated their plasma. And then those units of plasma were tested to make sure that they had sufficient neutralizing antibodies present. And this is what they called COVID. So it's a COVID hyperimmune globulin, and they called it COVID. And they gave to about half of the patients in the study. And what they were looking for in this study was severe COVID-19, including all of the poor outcomes we know are possible, like going to the ICU or needing mechanical ventilation, and also death. And as I mentioned, this was a small trial, only 18 patients, and these are patients with different types of blood cancers or organ transplant recipients or different types of immune deficiency or autoimmune disease. Their average age was 58 years old, and they had all received at least one vaccine. Remember, we don't know how great a response they got to that vaccine. And what they found was a surprisingly strong effect of the COVID. So severe COVID was observed in only 20% of the patients treated with COVID, compared to 88% who ended up with severe COVID in the control group who did not receive that immunoglobulin. So why is this a big deal? Well, as I said, we've lost our monoclonal antibody treatment, and we don't know if or when we're going to get them back. And it just might not be practical, or maybe it's too costly to come up with a new monoclonal antibody treatment every time we get a new variant that gets around the monoclonals, because monoclonal antibodies really have to be matched precisely to the strain that you catch in order for it to work. And at the rate that SARS-CoV-2 has been evolving, we've had to change our monoclonal antibodies actually more than yearly. And surely there's been quite a bit of waste because of this, because we can't use the ones that don't work. And the amount of effort and expense that goes into it may just not be enough to motivate manufacturers going forward. And so in this case, I think something like the COVID immunoglobulin treatment could be a good alternative, or maybe a backup plan, because we can get convalescent plasma from recovered COVID patients. We have no shortage of recovered COVID patients. So this could be easier than manufacturing entirely new monoclonal antibody treatments. So still early, still a small study, but in conclusion, I think the plasma-derived antibody treatments like COVID are promising for reducing the risk of severe outcomes of COVID-19 in severely immunocompromised patients. And this is something that should be considered when there's no monoclonal antibody therapy available for them. So some potential options and hope on the horizon there. The next innovation is in an earlier stage and maybe a bit more aspirational, but I think we should all keep hoping. This is an inhaled COVID-19 vaccine from Canada, which is entering into its phase 2 human trials. And this is from a company that has been doing a lot of inhaled vaccine research before COVID, like for tuberculosis, and they've already had some positive results from their preclinical trials that showed that their COVID aerosol vaccine may be more effective at creating an immune response than the injected vaccines. Phase 1 of their human trial has been evaluating the dose and the side effects in 30 healthy volunteers. And this is apparently progressing well as they're getting ready to enter into phase 2, where they will assess the immune response to the inhaled vaccine in about 500 participants. And this will include those with underlying conditions, so a better representative sample. The hope here is that the vaccine will generate what's called mucosal immunity, or immunity of the mucous membranes, which is where the virus enters, like through the nose. And it might be more effective at stopping infections and therefore better at stopping transmission. So we've been saying for a while that we're very lucky to have vaccines that are really reducing the risk of hospitalization and death. But if we want to see the end of the pandemic, we are going to actually need to slow down transmission. And we can do that in a number of ways, but the current strategy that we have of trying to update the vaccine and maintain some level of protection by repeatedly boosting is great for preventing those severe outcomes, but it kind of leaves us chasing behind COVID, and it's not stopping transmission. So this is why we should still be trying to stop rampant transmission by improving indoor air quality, continuing to mask. But it would really be remarkable if we had an actual vaccine that not only protected us against the severe outcomes, but also prevented us from catching and transmitting COVID. So another thing to be hopeful for. And the last thing I wanted to just touch on is that both the FDA and CDC have signaled that they are working to simplify guidelines related to COVID, the vaccine, the boosters, and COVID testing. So on Thursday, the 26th of January, the VRBPAC, which is the advisory committee to the FDA, will have an all-day meeting to discuss a number of items, including simplifying the vaccine regimen and to discuss whether harmonizing the booster composition as it relates to monovalent versus bivalent is going to be a recommendation. And they'll be reviewing data on the Omicron booster as well. I've linked the agenda in the post, and of course that is a public meeting in case you're inclined to watch. The CDC has also signaled that it intends to provide more straightforward guidance on what test to use when. I think we're all fairly well versed in this, but it will help to get clearer guidance from the CDC, so we'll be keeping an eye out for that as well. In the meantime, make sure you stock up on rapid tests. Get your 4 from the government, get as many as you want from Roots Community Health Center. There are other community-based organizations and clinics that are distributing them as well. These tests are definitely not perfect, but they are a good layer of protection, especially for pre-event or pre-gathering testing. For anything else, you really need to repeat them every day or two while you're continuing to wear a filtration mask. PCR is really the best if you're not feeling well, especially if you're someone who will be treated if you turn positive, and so that you don't spread it to others. We cannot really rely on antigen tests for this because it takes longer for them to turn positive. And so if you don't know where to get a PCR test, we are doing them at Roots. There are still some community sites for that. You should also check with your primary care provider, your primary care doctor. Everyone should really be doing COVID testing in the office now. If you don't have a primary care provider, please get one and know how to reach them before you need them. Find out if do they have vaccines? Do they have boosters? Are they going to give you COVID treatment if you are someone who should get it? And what is the plan for that? And do they do COVID testing within their office? Get up to date on your boosters. And please, let's all do what we can to avoid getting infected or reinfected. Gather outside, improve indoor air quality, wear a high quality filtration mask like an N95, a KN95, or a KF94. If you do catch COVID, please get treatment if you are eligible. And as usual, remember to eat a balanced diet, get some exercise. Unless you're sick with COVID or you're fatigued post-COVID, in that case, please get your rest. It just may reduce your risk of long COVID. Manage your stress, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you again next Tuesday at 10 a.m. See you then.